All right, hello everyone. Welcome to Surgery 220, where we are going to start really diving into procedures. We are going to start with Chapter 23, which is General Surgery. You will notice that I'm going to do these ed puzzles a little bit differently, so I'm going to go through this lecture here and just cover basically the main body of the chapter, the main informational points, and then we will go through the procedures together in class. If I had done them all together in one PowerPoint here, that would have made for a very, very long ed puzzle. And I think it'll be more beneficial for us to go through those surgeries together in class where we can discuss them, watch videos, answer any questions, things like that. So with that being said, we'll get started on Chapter 23, which, like I said, is general surgery. Right, so we're going to start with just a little bit of an introduction here. General surgery is going to include all procedures of the abdomen and non-cosmetic breast procedures. This is going to include the abdominal wall, the GI system, the biliary system, which includes the liver, gallbladder, pancreas, things like that, the spleen, the pancreas, the hepatic system, and the breast. These may also include some superficial procedures that rarely extend deeper than that subcutaneous fat layer just under the skin. And that's going to be our lesions, lipomas, sebaceous cysts, and things of that nature. All right, so we're going to start off with section 1, which is going to cover the abdomen. All right, so just a brief review here for some structures and regions of the abdomen. The body is divided into semi-closed compartments or cavities, and these cavities contain specific anatomical structures and organs. The cavities are separated by membrane, muscle, and other connective tissues. We do have the abdominal cavity, which includes our abdominal viscera, which are also otherwise known as organs. The pelvic cavity houses our reproductive, genitourinary, and lower GI systems. And then our retroperitoneal cavity is going to encase our kidneys, adrenal glands, and our ureters. The abdominal cavity is separated from the retroperitoneal cavity by a posterior abdominal peritoneum. That was a mouthful. All right, our abdominal area is divided into 4 major quadrants, which I'm sure you're all familiar with. I've abbreviated them here, and that is our right and left upper quadrants and our right and left lower quadrants. The abdomen, as far as surgical considerations are concerned, is further divided into 9 regions by an imaginary grid, and we will go over that in just a slide or two. So here's just a brief illustration of our 4 quadrants, that being our right upper, right lower, and left lower quadrant. And these are going to be important. They're going to help you familiarize yourself with where your incisions may be, depending on what portion of the anatomy we are working on, or the abdomen, I guess I should say. And here's an illustration of those 9 regions and that grid that we have talked about just a few slides ago. They are listed here: left hypochondrium, the epigastric, right hypochondrium, right flank, umbilical, left flank, and then the right and left iliacs and the suprapubic region. Knowing these quadrants, like I said, and the regions are going to help you figure out positioning and planning for future cases. For an example, an organ located in the inguinal area is going to be either in this right or left iliac region. Organs in the rib area will be in the right or left hypochondriac regions. Okay. So that is a good thing to review and familiarize yourself with. That will help you in future endeavors as far as surgery is concerned. All right, just a review of some abdominal tissue layers. These tissue layers are going to enclose the ventral or front part of the abdominal cavity. They extend from the ribs to, extend from the diaphragm to pubis. And the tissue layers are going to include these things listed here: the skin, subcutaneous or fat layer, our fascia, muscle, peritoneum. Okay, they're often, as we know already, sutured separately, and the suture materials for each layer are going to be strong enough to approximate or bring together the layer after it's been surgically cut, but it's also going to be fine enough to cause as little trauma as possible. Okay, and I just want to talk briefly about each of these. The skin and subcu are contiguous, which means they share a border or they touch. Okay, the muscles are going to cross each other and attach at different levels of the fascia. Muscles and fascia protect the abdominal viscera. Okay, they move the body in flexion and rotation, and they kind of also assist in respiration and bearing down. Okay, muscles that are worth noting when making surgical wounds are the two longitudinal rectus muscles, the three flanking muscles, and the three flanking muscles. Those are the transverse external oblique, internal oblique, and the transverse abdominis. And those are all listed here on this diagram. You can see here our transverse abdominis, our internal obliques are going to be over here. So you can see all of those here. They are good landmarks for us when we're working in surgery. The rectus sheath is a broad fascial layer that extends across the abdomen. And the rectus muscles are attached to that sheath at our linea alba, which is this midline fascial layer right here. It's an excellent landmark for us when we are doing surgery. Okay. The abdominal peritoneum is going to be a strong serous membrane that lines the abdominal cavity. It protects the viscera and it secretes serous fluid, which provides lubrication for our abdominal organs. Obviously, they are not stationary inside of us, so we want that lubrication to bring down that friction when we are moving around and breathing. The mesentery is an extension of the peritoneum. It attaches to the posterior wall and fans out to cover all of our small intestine. We also have a greater omentum. That is also an extension of that serous membrane, and it covers the stomach, duodenum, and part of the colon. So none of our organs are freestanding in our body. They are all attached to some sort of peritoneum or mesentery. And that is important to know when it comes to abdominal surgery, because those will always need to be dissected, mobilized, and transected for us to do any kind of removal or remodeling of any organs. And we'll go through that a little more detail in a few slides. But do know that those mesenteries are always going to be a part of our abdominal surgeries. All right, moving on a little bit into the inguinal region. We will talk about Hesselbeck's triangle in a little more detail here shortly, but it is a good landmark, surgical landmark to note when we're dealing with the inguinal region. Okay, the inguinal canal originates at the opening of the transversalis fascia at the deep inguinal ring, and it continues to the superficial inguinal ring. Like I said, Hesselbeck's triangle is a good surgical landmark. It's bounded by the rectus abdominis and inguinal ligament and the inferior epigastric vessels. It is subject to inguinal hernias. That is why it is one of our good surgical landmarks. Okay. It is a very large area in males, and that is why we see more inguinal hernias in males than we do females. Females can get inguinal hernias, but they are a lot more common in males, and it is because this Hesselbeck's triangle is such a large area in them. Okay, it also contains the inguinal canal also contains the spermatic cord, which contains these items listed here: the spermatic fascia, the cremaster muscle, genitofemoral nerve, the ductus deferens, lymph vessels, and the testicular vein and artery. That is in the inguinal canal, and that is what we, if you remember back from our inguinal hernias, what we are securing and protecting with that Penrose drain. Okay, so that is what we need to focus on. And we'll get into that more when we get into inguinal hernias in just a bit here. All right, we're going to move on to some abdominal incisions. Incisions for general surgery depend on the area that's requiring the surgery. It also depends on the desired cosmetic effect, and they're most often named for their anatomical position. These are the most common, but keep in mind other specific incisions may be used and named for their specific locations in other specialties. There is a table 23.2 on page 498 that goes into some good detail on these abdominal incisions. We're just going to hit a few of them here, so please make sure that you take a look and study that table. Okay, so we have our midline incision, which is what we're going to most often use to access the liver. We have the paramedian incision, which we will often use to access the pancreas. Our subcostals are what we might use to say if we're looking for the spleen. We have our inguinal, which is going to be down here, that we will use for our hernia repairs and sometimes some vascular procedures. McBurney's is the one that we use quite often. That's on our right lower quadrant here, and that's what we will use for an appendectomy. We have the mid-abdominal transverse, the Rocky-Davis, and then our lower transverse, which is also known as a Pfannenstiel. That's this green line here. We're most often using those if we're working on the uterus or C-sections. We will use the Pfannenstiel incision. Okay, but like I said, please do make sure that you review that table 23.2 on 498. That is an excellent resource for you. All right, now we're going to get into some hernias, the different types and what they are. Let's just, as a review, remember what is a hernia. It is a protrusion of tissue through a defect in the abdominal wall. They can be congenital. They can result from previous surgeries or injuries, and they most often occur in the inguinal and femoral regions, but they can occur in other places as well. These are the different types listed here. We have inguinal. They can be direct or indirect. We will go through those. Femoral, incisional or ventral, those are interchangeable. Umbilical hernias, the Spigelian hernia, and the strangulated or incarcerated hernia. And again, table 23.3 on page 503 is an excellent resource. It goes into detail on these types and descriptions for hernias. So make sure you do take a look at that as well. So we're going to start off with the femoral hernia. These occur most often in females. That's due to multiple childbirths, obesity, and weaknesses in the abdominal wall. Can create a weakness in the fascia, and that allows the herniation of abdominal tissue. The femoral sac is going to be sent for specimens on these. Most hernia sacs, if we transect them, will go for specimen. Just ask your surgeon. Okay, so as we said just a moment ago, it arises from a weakness in the transversalis fascia, right below the inguinal ligament. Occurs mainly in females. And our surgical goal for these is to repair the femoral hernia, to restore strength to the inguinal fore, and prevent abdominal tissue from protruding into that inguinal canal. And we can see here on this patient, it is right here. So our incision would be just above it. Right, moving on to our incisional or ventral hernias. This is a protrusion of abdominal tissue through one or more abdominal layers. Usually come from a previous abdominal incision that failed to heal completely, or later broke down because of obesity, infection, or disease. They may usually require a mesh to bridge and strengthen those tissue edges. Okay. Non-absorbable sutures from previous surgeries are usually present, and those need to be removed. Usually when we get through that skin and subcu and down into those muscle and abdominal wall layers, we will see previous sutures. We need to make sure that those are removed before placing any mesh and doing any repairs, because they can cause infection. All right, and a lot of times with these, the surgeon may try to establish some normal tissue planes. What that means is he's going to go through and try to remove as much of that scar tissue as he can, so that when we do put in a mesh, new scar tissue can form on a more normal plane and help strengthen that mesh. Right, with umbilical hernias. This is an abdominal wall defect that occurs at that linea alba, so our midline, at the umbilical ring. Okay, the repair is done again to repair the weakening of that abdominal wall, usually around or under the umbilicus. So we can see here this patient has a pretty significant umbilical hernia, and we can see what can cause happen here is that our viscera then is protruding through that defect in the abdominal wall, and that's what's causing this hernia here. Okay, obese patients are a little more at risk for umbilical hernias. They do, like I said, appear in our patients with higher BMIs. The sac of an umbilical hernia has a small base, which increases the risk for tissue strangulation, which we will go through in a minute here. But that is what can oftentimes make these surgeries, though it seems like a very small hernia there, it will put it into an emergency status, and we'll go through why in just a bit here. It is not uncommon for the ST to have to both assist and pass instruments at the same time during these cases, these umbilical cases. And that is because, as you can see here, it is a relatively small hernia and a relatively small repair, so they usually will not bring a first assist with them. So it's not uncommon for us to have to hold retractors and assist and pass instruments at the same time. Just something that's a little bit noteworthy for your futures when you get into clinicals and in the working field. Okay, moving on to the Spigelian hernia. You may also hear these called interparietal, interstitial, or intramuscular hernias. They are a rare hernia. They occur between the transverse abdominis and rectus muscles, so usually on those flank sides. They're rarely diagnosed, but they are usually seen during surgeries for other reasons. Quite often a laparoscopy is when we will see these because of the area that they're in. As you can see, this patient's here is on that lower flank through that abdominis muscle. So quite often when we are in a laparoscopy case, oftentimes for a chole or a hernia repair, an inguinal hernia repair, is when we will be able to view the inside of that flank wall, and that's when we'll see these and sometimes repair those as well. They are completed to reduce protrusion of the abdominal viscera in that what we call the Spigelian zone. I will tell you, in my career, I've probably only done about 2 or 3 of these, so they are incredibly rare. But we do see them every once in a while. All right, just a little review of the inguinal hernias and the direct versus indirect. So our direct hernia is a protrusion of the abdominal or inguinal tissue, and our keywords here for direct is that it is directly through the transversalis fascia. Okay, these are usually acquired in older males. So that is directly through the transversalis fascia. That is our direct inguinal hernia. An indirect inguinal hernia is when that viscera slides into the inguinal canal from the deep inguinal ring. Okay, so the herniated tissue may extend through that superficial ring and slide into the scrotum or labia. It can occur in females, but not as often. So direct is straight through that fascia. Indirect, it's going to go under the ring and into the scrotum or labia, into the canal. And just a quick little slide here on strangulated or incarcerated hernias. Those terms are interchangeable. So strangulated and incarcerated both mean the same thing. And this is when the tissue becomes trapped or strangulated by those surrounding tissues. Like I said, these surgeries are often considered emergent because that herniated tissue is now going to be deprived of a blood supply, and it can become necrosed or start dying. It becomes swollen, it gets squeezed, and then, like I said, that's when our ischemia and other complications such as necrosis are going to come in. As you can see, this loop of bowel here is twisted on itself. It's getting squeezed, now we're swelling, and all this darkened area, our tissue is starting to die due to ischemia. So we want to make sure that these are taken care of right away. That's why it may seem funny to you when you're out in your clinicals that this little, rather small umbilical hernia is an emergency surgery. This is why. A lot of times too, these patients are going to be in extreme pain. The smaller the hernia, the smaller the opening, the more the pain. It's one thing if this were opened here and here and those abdominal contents are coming through. It is not going to be as painful as them squeezing through this incredibly small opening. So that's something to keep in mind too when these patients come in and they are in extreme pain and then you see this very small hernia. That is why. Right, so we'll start into some case planning here. Both open and minimally invasive surgical techniques are used in abdominal surgery. Anesthesia can be general, local, or spinal. A lot of times, the smaller open procedures are done outpatient, and oftentimes our MIS procedures are done outpatient, okay? Meaning that they are going to go home the same day. Our patients are usually supine. A Foley is usually placed. It may stay in the patient pre or post-op, and it may be deseed or taken out right before they go to PACU or in PACU. It just depends on the length of the surgery. Okay, laparotomy instrument set is used for open repairs, and our MIS, or minimally invasive, is used for our laparoscopics, which you guys should be rather familiar with since we just went through our lap choles. Okay, surgical mesh is used for most hernia repairs. As the healing progresses, that scar tissue, as I said, is going to fill in with that mesh, and that's what's going to support the re-strengthening of that abdominal wall. Mesh does come in sheets or patches, and they can be measured and cut. They're very pliable, so we can customize them to our patient's anatomy during surgery. Okay, sutures are usually softer or more pliable silk or polyesters. Mesh, however, would be secured with a combination of both sutures and staples or surgical tacks. We'll get into that in just a little bit. Heavy Prolene might be used to secure mesh as well. And absorbable synthetic 3/0 sutures may be used to close up hernia sacs. Okay, so usually we are going to either purse string those sacs closed once we have them transected. All right, so just a brief review of these hernia procedures. We'll do this on this PowerPoint lecture here, and the rest we will go through in class since these are just a bit of a review. I know we went through them before. So the open repair of an indirect inguinal hernia. Our pathology, we are looking at a protrusion of the viscera into the inguinal canal. Remember, from that deep inguinal ring. In males, the tissue can extend into the scrotum, and in females, into the labia. Our position is supine. Our incision is going to be inguinal, in that inguinal region. Prep and draping are going to be laparotomy. We're going to use our laparotomy instruments. And then our extras are going to obviously include any mesh grafts and the Penrose drain. Remember, we are going to use that to secure and retract those spermatic cords. Now, on a laparoscopic repair of a direct inguinal hernia, our pathology, again, remember, that is the defect behind the superficial ring, directly through that fascia, located in the Hesselbach triangle. and usually acquired in older males. Again, our position is supine. Our incision is going to be a laparoscopic one. Our prep and drape, or we're going to do a laparotomy prep with a drape, and we're going to use our MIS instruments. Usually it's going to be 2 to 4 5mm trocars and 1 8 to 12 trocar or cannula. And then our extras again are going to be our mesh, our staples, and our tacks. Okay. All right, an open repair of an incisional hernia. Again, this is our type of ventral hernia. Usually develops at the site of a previous surgery. It can be complex with scar tissue and even fistulas that may form. But I'm thinking you're probably seeing a common thread here. Our position is supine, our incision is midline. Again, a laparotomy drape, laparotomy set, and our mesh graft. So I do realize that this photo over here is a laparoscopic photo, but it has a very good example of these surgical tacks here. Those are going to fire from a disposable instrument that is very similar in appearance to our endo GIAs and our endo clip appliers, okay, where it's got that trigger mechanism that will fire these tacks. And these are permanent structures that will stay with that mesh. And then here we see a percutaneous suture retriever. We can poke this through the belly. This is a Prolene suture here. So we'll poke that through and pull it back, and we can put knots into this mesh to reinforce it along with those tacks. And as you can see here, then all those openings in that mesh is where that scar tissue is going to form and strengthen that abdominal wall back up. So I do realize this is a laparoscopic picture, but it was a very, very good photographic detail of those tacks that I'd like you to see. Right. All right, moving on then into GI surgery. We're going to start off with a small review of our surgical anatomy. So we're going to start with the esophagus here. This is a tubular structure extending from the pharynx to the stomach. It moves food via peristalsis, which, if you remember, are involuntary muscle contractions. Reverse peristalsis regulates our stomach contents. And it enters the abdominal cavity at the level of the diaphragm, and it's about in an adult 10 inches long. So it is a pretty good sized tubular structure. All right, our stomach sits below the diaphragm in the upper left abdomen. It does have 3 distinct parts, those being the fundus, the body, and the antrum. The wall contains outer serosa, 2 inner layers of smooth muscle, and a submucosal lining of rugae. Remember these, if you remember from anatomy, these are folds in the submucosal lining of the stomach. That's referred to as rugae. That means folds. And that's what allows our stomach to distend when we eat and fill. Okay, the submucosa secretes HCl and pepsin, which are going to aid in getting that digestive process started and breaking down our food and stomach contents. Okay, the cardia is a anatomical structure that we need to make note of. That is an opening, or a sphincter, if you will, between the esophagus and stomach. And then we have the pylorus, which is a sphincter between the stomach and the duodenum. Okay, the omentum, as I said, we will have these sheets of tissue, connective tissue and vascular tissue. This attaches to the greater and lesser curvatures of the stomach. Whenever a portion of the stomach is removed or remodeled, that omentum is going to need to be divided from its attachments. So omentum is one of those sheets of tissue. All right, so here we have just an example, a little diagram of the stomach. As you can see here, we have the esophagus. Here is that cardia sphincter between the esophagus and stomach. Our fundus is the top. Our body is the middle of the stomach. Our antrum is going to be the lower portion of the stomach, and there's that pyloric sphincter as well in between the duodenum and the antrum. Okay, here we have the lesser curvature, and over here along the outside of the stomach is going to be the greater curvature. So you can imagine, just as an example, if we were doing, for instance, a laparoscopic sleeve, gastric sleeves procedure, we are going to need to make sure that we transect and divide that omentum all along this edge before we can remodel the stomach right here. Okay, so everything is connected to something else and must be divided. All right, moving on to the small intestine. It is the proximal portion of the intestinal tract. It does have 3 anatomical sections. Those are the duodenum, the ileum, and the jejunum. All right, the duodenum is 8 to 10 inches long. It receives chyme from the stomach. If you remember from anatomy, chyme is the byproduct that is left once that HCl and pepsin have broken down all of the stomach contents. That's what's left, is chyme. It also has the pancreatic duct. The common bile duct also drain into this section. Okay. Moving on from there, we have the jejunum. This is approximately 9 feet long. So we have a lot of small intestines in a very small space in our abdominal cavity. The jejunum is going to connect to the distal end of the small intestine, which is the ileum, and that itself is 13.5 feet long. So a lot of intestine. And this, of course, is all covered by the mesentery. So we have that omentum, greater omentum, which we'll get into in a minute, and the mesentery. This is the vascular tissue sheet that suspends the jejunum and ileum from the abdominal wall. So remember again, as I said before, none of our organs are free floating. They are all connected to something. And in this case, it is the mesentery. So during a resection of that jejunum or ileum, that mesentery is going to need to be clamped and divided. Okay, and remember, just as some further review, the intestine's function is to break down food into component parts and then absorb it. And the small intestine terminates at the cecum, which is the first portion of the large intestine. Okay, moving on then into the large intestine. This extends from the distal ileum, remember, which was the end part of our small intestine, to the rectum. It does have 5 distinct sections and is approximately 5 feet long itself. One anatomical thing that we want to note is the haustra. These are a series of puckers that are formed along the axis of the colon. And they're formed by contractions of a longitudinal band of muscle that are called the tinea coli. Okay, so each of these is going to be our haustras, these little puckers here. Okay, and here we see our tinea coli. And our 5 sections are our ascending colon, our transverse colon, our descending colon into our sigmoid colon, and our rectum. All right, so moving on, the final part of our digestive tract is our rectum and anus. These are the distal 4 to 5 inches of the intestine. Okay, there are 2 sphincters. The internal sphincter, which is right here, is going to be a smooth muscle, so that is involuntary. And our external sphincter is going to be made of striated muscle, which is voluntary muscle. Okay, so knowledge of these structures and the pathology of the GI system is going to directly, as I said before, contribute to your ability to anticipate the need for instruments and for sutures and for critically thinking and possibly predicting any kind of ESUs or additional things that we may need. Knowing these kind of key structures and key landmarks are going to really help you in your critical thinking, assisting your surgeons. Right, so we're going to move into some diagnostic procedures. Gastrointestinal disease is confirmed primarily by imaging studies, blood and metabolic studies, and physical examination. However, Endoscopy is often performed before an open or laparoscopic surgery for biopsies and visual examination of the GI tract. Okay, we'll also use contrast studies under fluoroscopy, which is X-ray. These are often done to outline some anatomical structures prior to surgery. And then we also have the MRI and CT avenues as well. All right, case planning for these. Thermal regulation in GI and abdominal surgery is a very high priority. Okay, we have got these abdominal cavities open to the surgical environment, which we all know is very cold. It is often a large area that we have prepped and draped and exposed. So these patients get very cold, and they get very cold very quickly. So thermal regulation is a very high priority for us. All right, sequential compression is also used to prevent DVT for these patients. You may have noticed them on our mannequins in the lab. Those are those stockings that are wrapped around the calves of our mannequins. Those are connected to a machine, and it provides a sort of a massage throughout surgery to keep that blood and circulation flowing through those distal limbs. So those are also used almost every single surgery. Our patients will have those on. Okay, positioning for most GI procedures is also going to be supine. There are a few exceptions when we need access to that perineal area, such as a low anterior colon resection or a sigmoid colon resection, but we will go through those in class a little more detail together. And patients undergoing surgery for morbid obesity require extra attention for positioning and safety as well. The OR table needs to be able to accommodate up to 800 pounds. That is usually written and labeled somewhere on the operating room table, or they will be at your facility's front desk. So it is important for us to know exactly how much weight each of our tables and pieces of equipment can accommodate. It's pretty much everyone's job in the OR to know those things when it comes to patient safety. Okay, there are different extensions that can be added to our tables for our obese patients, but one thing we need to keep in mind is that we need to make sure we have the proper padding for those extensions. Everything needs to be well padded. And we need to make sure that we are taking extra care when we're transferring these patients to the gurney and the OR table. That extra weight sometimes requires some extra people and maybe some extra equipment, extra sliders and roller boards, or maybe even some pneumatic type lifts to assist in moving these patients, both for their safety and for ours. Okay. All right, as far as instruments are concerned, again, basic laparotomy set, atraumatic, grasping, and vascular clamps. Okay, so a common thread, again, our laparotomy set. Surgical stapling instruments, both open and laparoscopic, depending on what type of procedure we're doing, will be used. If you remember from our instrument chapters, this is going to be our TA, our EEAs, and our GIA staplers. Okay, and then sharp dissection, is usually done by Metzenbaum scissors or tonotomy scissors, which we've not learned yet, but you will. Our Bovie, harmonic, and ligatures are all very commonly used in these surgeries. All right, Babcocks are usually used on intestinal tissue and smooth forceps for suturing those mucosal layers. So Babcocks are very common when using these. Okay, resection of the bowel or stomach is going to need, as I said, the atraumatic clamps and stapling devices. So the reason that we're using those, remember, is that our atraumatic clamps are going to leave a small gap between the jaws, so that prevents crushing. So that is why we are only using our atraumatic clamps during these surgeries, and Babcocks, like I said, are ideal for that. All right, just some additional equipment and supplies. As I said before, our Bovie, ligature, harmonics, vessel loops may often be used for vein retraction. Ultrasound probes, such as our Doppler, may be used. Bowel bags are another thing that may be used quite often, especially when we're doing those bowel resections. These can go over the intestines when we have them outside of the abdominal cavity for protection and to keep them moist. Ostomy bags for our colostomies and ileostomies, our ureterostomies. They may be permanent, where the patient is going home with them, and that will be a permanent fixture for the rest of their lives, or they may be temporary and they may come back and be taken down in a few weeks after healing occurs. Okay, and we might also use wound protectors. And just a little bit of tissue approximation here. Sutures, closure usually performed, as we know, in layers. Fine absorbable taper needles are used for mucosa and submucosa. Silk or synthetic is going to be used on our serosal layers, also on a tapered needle. Remember, these are delicate tissues, so we want to use a fine tapered needle. Okay, large vessels and vascular bundles are ligated with either sutures, clips, or a sealing instrument. And large vessels of the omentum and that mesentery that we've talked about can be secured with either O or 2O ties or sutures. The difference between those two being, remember, our ties are going to have no needle on them, whereas our sutures do. All right, some of the techniques that are used in GI surgery we'll go over briefly here. There is a table, 23.4 on page 512, that I want you guys to pay special attention to and study. It is the surgical techniques used in the GI system. It's got some terminology, the definition, and an example of them. So that is a great table for reference. I'd like you guys to make sure you study. Okay, a few things from that table. Mobilization is going to be the clamping, cutting, and tying of omentum and mesentery to allow for resections. So that is mobilization. That is different from division. Okay, division is a procedure in which one section of tissue is cut away from another. Okay, anastomosis is basically means ostomy. That is the joining of two hollow structures. This is when our surgical staples are most often used. And there are two options when it comes to an anastomosis. Okay, we have the side to side, which is aligning of two linear parts. So a linear staple is needed, our GIA. And then we have the end to end, which is the joining of two ends of bowel. And that's going to require our end to end or our EEA stapler, which is what you see illustrated over here. Okay, there are a couple of other terms that are pretty important. One is a cross clamp technique. Okay, and that is when we place one or more clamps at a right angle to a tube or structure. That is cross clamping. Okay, double clamping is when we place two or more clamps over a section of tissue to prevent bleeding when the tissue is severed. Okay. And again, these terms are on page 512 in that table, so please do make sure that you pay special attention to that. These are techniques that are used almost every surgery, so they are important to know. Okay, just a little bit more on bowel technique. We need to make sure that precautions are taken to prevent contamination of our instruments and supplies by the bowel contents. Okay, so remember that what is inside the bowel is not sterile, it is not clean, it is contaminated. So instruments and supplies that are used while that bowel is opened are going to need to be kept separate from all of our other sterile items, either on another back table, a separate Mayo stand, however you want to use it and however your facility does that, but those instruments are going to be used separately. Okay, after the bowel is closed, those contaminated items are going to be removed from the sterile field. AKA, we are going to move that Mayo stand back and away, or that back table back and away. We are going to change all of our gloves. because anything that we have touched, remember, that has come in contact with those bowel contents is contaminated, so that will include our gloves. And in some cases, every once in a while, we need to change our gowns and our gloves. Okay. One thing to note then too, once those items are removed from the sterile field, when it comes time to count, it is important, and it is just a courtesy to try and lay them back out nicely, because when it comes time to count, it will be your circulator that will have to handle those things, because obviously we are not going to go back to those. We do not want to cause any kind of an infection or contamination. So that is why we make sure we take special precautions to keep all of those things separate from our sterile clean field. All right, so let's talk a little bit about endoscopy. This will be a bit of a review in some sections, but it is often used in combination with GI surgery. So if you recall, it is an insertion of a flexible tube into a natural opening in the body. So our oral, anal, even nostrils, anything that is a natural opening. Okay, most often performed in an outpatient setting, though sometimes we do them intraoperatively with these cases. And they're done under light to moderate sedation when they're in that outpatient setting. And if you remember, the purpose of these is to establish or confirm a diagnosis, to perform selective surgical procedures like those biopsies that we've talked about, and oftentimes for post-op inspection of surgical sites. So if we've done an end-to-end anastomosis, they may want this patient to come back for colonoscopy to confirm that that anastomosis is healing from the inside properly, there's no leaks, it's intact, things of that nature. So we have an EGD as a type of endoscopy that is done of the esophagus, stomach, and that proximal or top part of the duodenum. Okay, purposes, we may be biopsying, we may be doing sclerotherapy of varices, polyp removal, we may use it to do a gastrostomy for a feeding tube placement, and dilation of the esophagus. These patients are usually in the left lateral position, and a bite block is placed in their mouth that will protect their tongue and teeth and allow for a continuous opening for us to get that endoscope in. One thing to note is that these patients may have a delayed return of the gag reflex when we do these, and that is because we will oftentimes spray a local anesthetic into the back of the throat, just to kind of numb it up and cause more comfort for that patient when we're passing the endoscope. And this is just an example of what those bite blocks may look like. As you can see, they come in different sizes, all the way down to pediatric and neonate. Okay, they've got usually an elastic band that will hook here, go around the patient's head, and hook back up here. And then as you can see, this would be the portion that is inside of the mouth. These holes are on the outside, and this allows the opening for our scope to go through. Okay, so just an example so you have an idea of what those bite blocks are going to look like for endoscopy. All right, a colonoscopy. This is an endoscopy of the large intestine. The purpose of these is usually for a removal of polyps, biopsy or removal of lesions, coagulation of diverticula. Diverticula are pockets that often form as we get later in age in our large colon or our large intestine. They're just small pockets that can collect food and sometimes feces. They can get infected quite often, and that is when sometimes we need to do a bowel resection for, you may have heard of diverticulitis. It is very common for our older population to have that disease. Okay, we might do laser treatment for small tumors and oftentimes screening for cancer. As I said before, this may be done intraoperatively in combination with like our lower anterior colon resections, which we will go through together. And these patients are most often in the left lateral position. Now, all that being said, we can also do what's called a sigmoidoscopy, which is a endoscopy of the sigmoid colon. These are usually performed to examine tissue and obtain biopsies or specimens of the sigmoid colon and the rectum. Okay, these patients, when they do or have these done, are usually in a prone or lithotomy position. And there is one small difference with a sigmoidoscope versus a colonoscope, and that is that the sigmoidoscopes do not have built-in suction. So as a tech, if we are doing that, we will be helping with suction and irrigation, as those sigmoidoscopes do not have those built in, unlike our other endoscopes. Okay, moving on to the biliary system, liver, pancreas, and spleen. And just a reminder, guys, I know that we have skipped over those procedures that are in the chapter, but like I said, we will go through those in class. We are just getting the main body of information here. So just a small review of the liver here. The liver, gallbladder, spleen, and pancreas are located in the mid-abdominal cavity. The liver occupies most of the right upper quadrant and a small portion of the left upper quadrant. Okay, it's a large, very vascular organ. It aids in digestion and the filtration of toxins. The right and left lobes are separated by the falciform ligament, which is often a good surgical landmark that we are using. And you can see that right here. That is our falciform. Okay, it's encapsulated by the Glisson capsule, which is continuous with the abdominal peritoneum. So again, remember, nothing is free floating. Everything is attached to something. And the anterior surface is in contact with the diaphragm. That's referred to usually as the right and left subphrenic spaces at those two points where it attaches to the diaphragm. One other space that I'd like you guys to be familiar with is the subhepatic space. Okay, that's the one that lies between the peritoneal covering and the right kidney. This is clinically important, or clinically significant, if you will, to surgery, because this is a common site of abscesses, and entrapment of the intestinal contents following an appendix rupture. So infection easily occurs when this happens. So that subhepatic space is very clinically significant to us as STs. All right, now the biliary system as a whole includes the gallbladder, the hepatic ducts, the common bile duct, and the cystic duct. The function of this is to produce, store, and release bile. And if you remember, bile is necessary for the breakdown of cholesterol, and it helps stimulate peristalsis through that digestive tract to keep everything moving. And if you remember from our lap choles, we want to transect the cystic artery and the cystic duct. We never want to cut the common bile duct. Okay, and the reason for that is because, as you can see, the cystic duct and the cystic artery are coming off of the gallbladder. So we can, and that is what we're removing, so we can safely transect those. We do not want to cut this common bile duct because that is coming straight from the liver, and that is what's going to drain our bile into our digestive tract. If we cut that, we have lost all access to bile, which is necessary. So that is why we never want to cut that bile duct. We are always looking for the cystic duct. All right, moving on to the spleen. This is a soft, vascular, kidney-shaped organ. We find it in the upper diaphragm, or under the diaphragm, in that left upper quadrant. Okay, and the function of this is to destroy our aged red blood cells. It stores and filters our blood, and it has a pretty major role in our immune system. So something that is of note for the spleen is because of the vascularity of it and the location, it is often injured in sports and vehicle accidents. Okay, that being said, the spleen can be removed safely without harming the body's ability to function. And this is usually indicated whenever there is a splenic hemorrhage that becomes life-threatening. The spleen has very friable tissues, meaning they are very delicate tissues. A lot of times handling and working and trying to repair the spleen results in more damage to the spleen and more bleeding. So it is often best that we just remove it entirely to stop that hemorrhage and stop that internal bleeding. Right, so case planning for these procedures. Again, common thread, we're going to use our basic laparotomy instruments. However, we're going to add a few things to them as we just discussed. These are all very vascular areas and vascular organs. So we are going to want to have those vascular instruments, if not open and counted, at least available and ready to go if needed. Right angle clamps are also a must in abdominal and GI surgery. There are, as we said, a lot of vascular organs, and we will use those to get in and around and behind those vascular structures and those deep arteries and veins to tie them off. So right angle clamps are a must. Some special equipment and supplies that may be used are ultrasonic scalpels, our bovies, vessel loops, dissecting scissors, high frequency vessel sealing, so our ligature, and then our hemostatic agents. If you'll recall from our pharmacology chapter, our Avitene, Surgicel, gel foam, that is where these are going to come into play. Right, and moving on to the final section, at least for the body of this chapter, we're going to go into a little bit about the breast surgeries. So just a review of the anatomy here. The breasts are composed of glandular, connective, and fat tissues. They are contained within extensions of fibrous ligaments. And each breast actually has about 15 to 25 different sections. Glandular tissue forms sections or lobes that are interspersed with alveoli that will secrete milk. Right, the lactiferous ducts branch to connect the lobes to the nipple. The nipple contains glandular, vascular, nerve, and epithelial tissue, and they are usually centered in the areola, which is the darker skin of the breast that's around the nipple in a circular area. Estrogen and progesterone are secreted cyclically and during pregnancy, which oftentimes causes that areola to darken, and they may also see what are called Montgomery tubercles, and these are tiny bumps that form around the areola when pregnancy is discovered. Breast tissue changes with hormonal changes, pregnancy, and our nutritional states. And something that we need to make note of is the upper thoracic lymph drains into the axillary lymph nodes. This is clinically important. Cancer staging and diagnostic surgery often require us to take a biopsy of one or more of those axillary lymph nodes. So it's important to know where those are and what drains into them, because that is usually what we are working on when working with breasts. All right, so moving on into breast cancer, most non-cosmetic procedures of the breast are for the treatment of cancer. It is the leading cause of death in women aged 20 to 59 in the U.S. Now improvements in diagnostic technology and public awareness of breast cancer has increased the number of cases that are reported each year. However, on the flip side of that, advances in medicine have also decreased the number of radical surgeries we're using for treatment now. So we are not seeing nearly as many of those mastectomies or radical mastectomies as we were, say, 10 years ago. So that is a good thing. Invasive ductal carcinoma is our most common type of breast cancer. Risk factors include family history and hormonal changes that result in late menarche, which is the onset of menstrual periods, and late menopause. 0.8% of breast cancer is in men, so it is not a female-dominated thing. Men can get breast cancer as well. However, the average mortality rate for men versus women is 400 to 400,000. So obviously much, much more common in women. Okay, and then cancer staging is sometimes done surgically, and that determines our outcome and our treatment possibilities, is when we bring these women in for cancer staging. As far as case planning goes, psychological considerations for these patients are very, very important. We need to be mindful that the breast for women really reflects reproductive ability, body image, and femininity. So when we are coming in surgically to disrupt these things, it is not uncommon for these patients to have extreme anxiety, fear, and even depression. So even as an ST, it is incredibly important that we are providing emotional support when that patient comes into the room, which can be something as simple as a greeting and an introduction. Okay, we want to make sure that the atmosphere of the OR is calm and professional. You know, the music is turned down. We are not making a bunch of noise, moving instruments around and setting up. You can set up quietly. And we want to make sure that we're maintaining that patient's dignity and respect. We're keeping them covered. We're minding their privacy. We're mindful and respectful of whatever emotions they may be showing, if any. It is just a huge psychological consideration when we're doing these patients' procedures. Okay. As far as prepping and or positioning and draping, non-cosmetic procedures are going to be in the supine position or sometimes a modified beach chair, but most often supine. A pad may be placed under the operative side just to give a little bit of gravitational help when accessing these different areas of the breast. And the affected arm, aka the operative side arm, is usually prepped and draped free in case of an axillary node dissection, which is usually what we're going to be doing. And this is an example of that. So we have prepped out the entire surgical area here. As you can see, we just used the laparotomy drape. However, we've also done a circumferential prep of this entire arm. Even though we've covered it, the entire arm is prepped to the fingers all the way around. And then we've put a stockinette over the hand. We have small stockinettes for the arms. So if you remember from our knee scopes when we use those, we'll grab onto that hand and arm with a stockinette, and then we'll wrap it in either a Coban, an ACE, or even here it looks like they just used a bit of gauze. And the reason that we do that is so that we can manipulate this arm then above the patient's head, over their chest, however we may need to get to this incision right here and those axillary nodes, which may be superficial, but they may be very deep, and that is where having this arm free is going to help us so that we can maneuver and get those out.